Let's do one more of these, then let's switch gears to some interstitial lung disease. So what about, folks, this 30-year-old woman is evaluated in ED after she was rescued from her home where her leather sofa caught fire. A lot of fire questions tonight. She is intubated. She's unconscious. Probably her Glasgow coma scale was very low on exam. She's normotensive. Heart rate of 100, respiratory rate of 24 on the vent. O2 stat's 100%. Her O2 stat is 100% on the vent, but she's on 50% FiO2. She is unresponsive. She has no visible burns on her skin, and her airway secretions are clear. Brainstem reflexes are all intact. And so we have serum labs. Sodium looks normal. Potassium is normal. Chloride's normal. Bicarb is low at 13. Oh boy. We have an arterial blood gas. pH is low at 7.29. PaCO2 is 28. So just right there, it seems that the patient has the metabolic, that's right, metabolic acidosis. And anytime someone has a metabolic acidosis, you really like to know, is there a gap or not? And you know what? We got the sodium, the chloride, the bicarb, and the answer is, yeah, looks like there's an ungap metabolic acidosis. And of course, we could take it all the way and we could calculate compensations. And of course, for the pulmonary boards, they are going to have triple acid-base disorders. But for time's sake, it really looks like there is an ungap metabolic acidosis going here. The PaO2 is really good. Doesn't seem hypoxic at all. The carboxyhemoglobin level, being in a house that caught on fire, is normal, and the methemoglobinemia. So they did probably brought the arterial blood gas to a co-oximeter. So the methemoglobin level is also normal. And look at here, the lactic acid is elevated, probably reason why she has that ungap metabolic acidosis. All right. So which of the following is the most appropriate treatment for this patient that we're talking about here? With the house fire and a leather couch, I guess the choices are A, hydroxycobalamin, B, hyperbaric oxygen, C, methylene blue, and D, a nitrate, sodium nitrate. All right. I got to tell you, I think I'm really liking this question. I wish I could see all of you. What do you folks think is the right answer? Well, let's do our process of elimination, okay? So which one of these do you feel you could probably cross out before we start analyzing what she has? I'm pretty sure we could take out hyperbaric oxygen. Why? Well, number one, it's going to be pretty tough. She's intubated on the vent, but her carboxyhemoglobin level is what? Normal. All right, so it's not carbon monoxide toxicity. Should we? Yeah. C. Does she need methylene blue? Probably not. Her hemoglobin level is what? It's normal. Okay. So I'm kind of bullied into hydroxycobalamin and sodium nitrate. So what does she have, by the way? What can you get inhalationally in a house fire that can give you an ungap metabolic acidosis, specifically a lactic acidosis? Yeah, I kind of gave it away, didn't I? I'm sorry. It's probably cyanide toxicity, and we see that quite commonly with carbon monoxide toxicity. And what did I say? How do you die from, cyanide toxicity? It inhibits oxidative phosphorylation. So if you inhibit it, you can't make what? You can't make ATP, and you need oxygen to make ATP. So what's going to happen? You're going to start developing a lactic acidosis. So this sounds like cyanide toxicity. And with that being said, what's the right answer? Hydroxycobalamin, or do you want to induce a methemoglobinemia with a nitrate? And the answer is A. A is an apple. So many of you are asking why. So, I'm not taking back what I just taught you on the following question. In the olden days, when we talked about how do you treat cyanide toxicity, sometimes you may want to induce a methemoglobinemia, but things have changed. And when someone's already hypoxic, on the ventilator, requiring 50% oxygen, you don't want to risk it and induce a methemoglobinemia and make things actually worse. And beyond that, there is an antidote now that you need to memorize. And yes, on our pulmonary and critical care boards, we still have to do a lot of memorizing. So hydroxycobalamin is actually, it binds to cyanide to produce cyanocobalamin, which is a soluble, non-toxic, readily excreted product, and that really is the antidote. And like I mentioned earlier, that inducing a methemoglobinemia, and especially in someone who's already on the vent on 50%, there's just too much risks of making things worse, especially now that we have a very safe antidote in these cases. And many times cyanide and carbon monoxide poisoning go hand in hand. So, I really hope, everyone listening really enjoyed those last three questions. They were always very confusing to me. Carbon monoxide, hemoglobin E, and cyanide, and what happens from an oxygen standpoint. All those are high yield for the boards, okay? So switching gears, let's talk about a 65-year-old woman with a 20-year history of Sjogren's. All right. Is seen for an abnormal CT scan. And there it is right here. And you guys can start analyzing it. She has mild non-progressive dyspnea on exertion, but no fevers, weight loss, or cough. On exam, her vital signs are within normal limits. Her with clear lung fields and heart sounds are normal. And no clubbing is noted. Labs have a hemoglobin that's normal at 13.5. Serologies, ANA, the titer is super high. Double-stranded also seems to be positive. SSA and SSB, which is anti-Rho and anti-La, they're both positive. And they got some PFTs. Total lung capacity is normal. FVC is normal. FEV1 is normal. The ratio, pretty normal. And DLCO at 85% also screams normal. She does a 6-minute walk. She walks 1,000 feet with an O2 stat of 96% on room air, and she's good. She doesn't need any supplemental oxygen. On exercise, it only went down to like 94. And of course, they got a high resolution CT scan of the chest. And I'm, putting it right here. And, what are we looking at? I think we see a lot of these cysts over here. So I see a lot of cysts, and of course, when we're talking about the pulmonary boards, do they love talking about cystic lung disease on the pulmonary boards? The answer is yes, right? Whether we're talking about Langerhans, histiocytosis, upper lobe, whether we're talking about LAM in women, they love cystic lung disease, right? And of course, many of you are talking about, people who have a very specific, idiopathic interstitial lung disease. They may have something called, lymphocytic interstitial pneumonitis, LIP. And you know what? People with Sjogren's can definitely develop, interstitial lung disease, but all I see here is a lot of cysts and what could be going on. So what is the next best course of action in this patient? You know what I mean? 65-year-old woman, mild non-progressive dyspnea. There's the PFTs. Doesn't require oxygen. So would you perform a surgical lung biopsy? A, would you start immunosuppressive therapy? C, perform serial imaging. D, broncher with some transbronchial biopsies. So a couple things. Number one, is this someone that you want to treat? Do you think that at this stage with those findings and, with her symptoms and PFTs, does she warrant therapy at this time? And, for me, the answer is no. If she's having worsening dyspnea on exertion, the PFTs having a reduced DLCO, FVC is on the lower side, yeah, maybe I would start it. Anytime I want to start immunotherapy, in most cases, I may want to just, confirm the diagnosis, especially in a patient like this. So I don't think we need to start immunotherapy. And because of that, I don't think getting tissue at this time is going to be, the most important thing because she essentially is asymptomatic. What would I do in this specific case? I'd probably just do some serial imaging. So let's talk about Sjogren's, which will be on your board, and some of the lung manifestations. So right here, 20% of patients with Sjogren's have pulmonary disease of clinical significance, but a much greater prevalence exists out there of asymptomatic abnormalities. So what does this sound like? Yeah, that asymptomatic abnormalities. So when we talk about ILDs, and this is, I wish we had all the time in the world. Of course, one way to categorize ILDs, according to the American Thoracic Society, is going to be having these idiopathic interstitial pneumonitis, and of course, that other branch is going to be secondary to rheumatological diseases. So Sjogren's, can give you an NSIP pattern, non-specific interstitial pneumonitis. They can give respiratory bronchiolitis, UIP pattern, usual interstitial pneumonitis. Of course, LIP, which this could be, and of course, something else called organizing pneumonia. And, ILD, in most of these Sjogren's patients is often indolent with a relatively stable lung function. One I really worry about it, of course, if you start saying UIP, we're talking about pulmonary fibrosis, and that could have a very horrible outcome in most cases. What does this CT scan show right here? It actually is more characteristic of something, and this is why I put the question here, is called follicular bronchiolitis. So, of course, many of you are going to ask me, what are you talking about follicular bronchiolitis? And I wanted to say follicular bronchiolitis exists on a continuum with LIP. And how do I kind of break this down just for this small question here is that, if you have follicular bronchiolitis, you'll have multiple cysts like in the CT scan, the one cut I showed you. When we talk about LIP, beyond just having multiple cysts, you usually will have a lot of ground glass opacities, which I didn't see in that cut. And you could have a lot of central lobular nodules. And we didn't see that either in that one cut. So remember, follicular bronchiolitis on a continuum with LIP. LIP has the ground glass and has some central lobular nodules. And I have another picture of that coming up. You know what I mean? And I stole my own thunder. Here is going to be this, cysts. This is an LIP patient. You see the ground glass, and there is some central lobular nodularity over there. How do we treat some of these, this ILD secondary to Sjogren's? Well, because it's a rheumatological disease, and rheumatological disease can give you any of these ILDs, we treat it two ways. Number one, inflammation, and number two, fibrosis. So for the anti-inflammatory component, of course, we work with our rheumatologist. For Sjogren's, oral medications like mycophenolate or brand name Imuran would be very reasonable to consider these medications. Of course, this is based upon side effect profile and dosing. And in severe cases, if they don't tolerate, a Celcept or Imuran, you can do IV infusions of rituximab in these cases. Usually that's given, every 6 months, rituximab being a biologic, and that's talking about inflammation. When we talk about the fibrosis component, there's only one medication that got FDA approval for essentially many different ILDs. In fact, almost all the ILDs with a very specific phenotype, this progressive fibrotic phenotype, this chronic progressive fibrotic phenotype. And once you hit this stage, and this can happen in people who have, an ILD secondary to Sjogren's, Nintedanib, which goes by the brand name OFib, definitely got FDA approval for this, and it decreases the decline in the FVC if you initiate this medication in these individuals who have that progressive fibrotic phenotype. So Sjogren's, I want to kind of whip through this part pretty quick because I want to get back to another question. I just want you to know that, Sjogren's can affect every single organ in the body. Sjogren's comes in two forms: primary, not really associated with other diseases, and secondary, that's usually attached to many other rheumatological diseases, most common being rheumatoid arthritis. Whether you have a primary or secondary Sjogren's, you could have what's called the glandular features. The classic ones are going to be the dry eyes and the dry mouth, or you could have extraglandular disease. And that's what we're talking about here when we talk about the lung, the extraglandular features of Sjogren's. Of course, on your boards, they love giving pictures to make you hint about what the diagnosis is going to be. Always think about xerostoma, the dry mouth, xerophthalmia, the dry eyes, salivary gland enlargement, huge parotid glands, submandibular glands. They have abnormally dry skin. We call that cirrhosis. Think about having these pictures on your boards. Of course, because of the dental caries from the lack of saliva, dentists often refer to, to rheumatology for Sjogren's. Look at the parotid gland enlargement. And of course, any rheum disease can have many different associations with skin findings. Beyond cirrhosis, you could definitely get annular erythema, erythema nodosum, which can also be seen in diseases like sarcoid, inflammatory bowel disease, fungal infections like coccidioides emetis, and of course, SLE and Sjogren's, or nonspecific things like livedo reticularis. And I wanted to put this to show you the extraglandular features, can be associated with, autoimmune pancreatitis like IgG4 disease. You can get lymph nodes and lymphoma. And of course, people, especially with primary Sjogren's, are going to have a very high risk of non-Hodgkin's lymphoma. You can develop renal tubular acidosis type 1 in the distal convoluted tubule. And of course, interstitial lung disease. And of course, I have a picture down here of classic honeycombing. This is a UIP pattern secondary to Sjogren's. So they could get, unfortunately, UIP and SIP. And like we mentioned in this particular question, a follicular bronchiolitis. We're just going to monitor at this time, and that's on the continuum with something like LIP. And if you want to make the diagnosis, the gold standard is always going to be doing a biopsy. We do it right here on the lip. We don't need to take out the parotid gland or anything. There's minor salivary glands in the lip, and it helps make the diagnosis. We don't do Schirmer's testing, as much anymore. Serologically, like in this vignette, they are classically ANA positive, and they could have an anti-Rho or anti-LA positive, which is otherwise known as SSB, SSA, and SSB respectively. Good. Let's see how many more we can squeeze out there. 45-year-old woman with a 3-year history of systemic sclerosis. Stop right there. Class, on the board exams, do they love scleroderma? Is that a gimme on the pulmonary boards? The answer is yes. So especially when we talk about rheumatological diseases, and I ask you, well, what rheum disease can give you pulmonary manifestations? The answer is, well, all of them, right? Well, there's dermatomyositis, polymyositis, and lupus or RA, but scleroderma always really seems to be a favorite on the board. So I really wanted to spend time with this. So we have a 45-year-old woman with a 3-year history of systemic sclerosis, presents to the clinic reporting increased dyspnea on exertion and dry cough. Exam vital signs are within normal limits. The O2 stat is 96% on room air. She has perioral skin tightening, classic for scleroderma. Lung exam reveals crackles at both lung bases. That can't be good. Cardiovascular exam has normal heart sounds. Extremities are notable for skin thickening, extending to the proximal to her PIP joints, but there's no clubbing or edema. Labs, she has an SCL70 antibody positive, otherwise known as an anti-topoisomerase. On labs, TLC is low at 68%, really defining a restrictive lung disease having the low TLC. FVC is low, less than 80, but not too low. FEV1 is normal, 82%. The ratio is on the normal to higher side, classic for a restrictive intrinsic lung disease. And DLCO is definitely reduced at 62%. And the TLC, FVC, and DLCO, all those have decreased since the previous set of full PFTs 6 months ago. So she has worsening dyspnea on exertion, worsening PFTs. Class, learners, does this sound like the previous question of the patient who had Sjogren's? The answer is not even close. That Sjogren's patient had, normal PFTs, really didn't have any symptoms, no harm in monitoring. This is going to be one of those, what is the next step? What are you going to do? How are you going to treat? So they got a high resolution CT, and wow, it looks like, you see traction bronchiectasis over here, maybe some early honeycombing down here at the bases. I could see why the DLCO is going to be low. So what medical therapy has demonstrated efficacy, keywords efficacy, with the least adverse effects? How do you want to treat this, folks? Should we give this patient Cytoxan, which is cyclophosphamide? Should we give this patient some mycophenolate, which is going to be Celsep? Should we do a little rituximab, Rituxan? Or how about pirfenidone, which is going to be an antifibrotic? So which one is, for me at least, going to be the wrong answer? Well, it's going to be pirfenidone, right? When we talk about these antifibrotics, we're not talking about idiopathic pulmonary fibrosis. When we talk about IPF, both pirfenidone and brand name Ofev got the FDA approval. But when we talk about these other ILDs, The only one that got the other approvals is going to be OFEV. And OFEV really had some studies when we talk about scleroderma patients, even though it got a broader indication when we talk about the progressive phenotype from all these ILDs. So D is wrong. C, I'm not saying you can't use rituximab when you have scleroderma, but for me, using a biologic is when you start throwing out some of these Hail Marys out there, right? And that's not going to be probably the first thing I'm going to use for scleroderma. It really comes down to A and B, right? And have we used cyclophosphamide for scleroderma? Definitely. Have we used mycophenolate? For sure. But which one's going to have the least side effects? Yeah, you folks are amazingly, I don't even need to be here. You guys are so awesome. Answer has to be what? B, mycophenolate. So let's talk about this. Remember the Sjogren's patient? Does anyone remember what percent of these patients have symptomatic ILD? Yeah, that was like 20%, right? This one, close to 80% of people with systemic sclerosis will have an ILD. And I'm not even talking about pulmonary arterial hypertension. You need to know that for the board exams. And especially now that there are going to be, there are going to be medications for pulmonary arterial hypertension, these inhaled medications that come in even in a dry powdered form. They got FDA approval for ILDs. Go figure. But back to this. You know what I mean? So, it's not surprising when we talk about scleroderma, patients get interstitial lung disease. They get UIP, they get NSIP, So there have been a number of rigorous trials looking at what? Cyclophosphamide versus placebo, or cyclophosphamide versus mycophenolate, or even nintedanib OFEV versus placebo when we're talking about this. And because when we're talking about, a interstitial lung disease secondary to a rheumatological connective tissue disease, you want to attack the anti-inflammatory as well as the anti-fibrotic. But today, we're really going to be talking about the anti-inflammatory. And I know someone who just knows way too much pulmonary is already mentioning, but Dr. Raj, you didn't mention tocilizumab. Don't worry. Give me 1 second. We're going to talk about tocilizumab coming up. So when we talk about the right answer, it's going to be mycophenolate. When we talk about mycophenolate in itself, you want to titrate it up to around 3 grams per day. Of course, getting baseline CMP and CBC. You want to watch for GI tolerance. You want to look for nausea. Sometimes some clinicians may use a Myofortec, which is a kind of a different formulation of mycophenolate for those who don't tolerate it. They want to stick with that category of drug. But, when we talk about cyclophosphamide, there's toxicities acutely and chronically. When you give cyclophosphamide acutely, it really suppresses the immune system. You really will wipe out those WBCs. Of course, chronically, every single person here memorized this. What chronic, side effect do we worry about with cyclophosphamide? You folks are amazing. You're right. Hemorrhagic cystitis. Therefore, we give what drug? Mesna. You folks are amazing. So I did put a little thing about tocilizumab here. Tocilizumab got the FDA approval. Don't get me started. For people who have interstitial lung disease secondary to scleroderma. It's 162 milligrams weekly by a subcutaneous injection. And, I still say that when would I consider this medication if you at this point can't tolerate, CellCept? As far as, comparing it to cyclophosphamide, tocilizumab is a biologic. It inhibits interleukin-6, IL-6, but it's a little less toxic than cyclophosphamide, but we don't have as much data when we talk about the use for tocilizumab compared to cyclophosphamide. Of course, when we talk about maintenance therapy, typically most people, when we talk about being on CellCept, we usually continue that for at least about 2 years, and we reevaluate on these for these patients. Refractory disease, once again, I mentioned rituximab, and this isn't a typo down here. Yes, people who have scleroderma, how do they die? From the lung. It's horrible. And yes, there have been trials doing stem cell transplant for scleroderma patients because they have horrible lung disease. So I'm going to whip through this part because, once again, I really want to make sure I get you as many questions as possible. But what they will ask you on the board exams for scleroderma is, how do you categorize it, everyone? Look at this little diagram up here. On your boards, scleroderma, really for you folks are we focusing on systemic sclerosis. Scleroderma has two main types, localized and systemic. Localized means it only affects one organ, the skin. People with localized scleroderma don't get involvement of the organs in the body, right? They don't get lung involvement, heart involvement, kidney involvement. It's only going to be skin involvement. And what is morphia? Someone's already asking me that. It is one type of skin lesion that you see with localized scleroderma. Systemic sclerosis means that it really could affect every single organ in the body, and we subcategorize those to limited and diffuse. What really separates limited from diffuse, everyone? The take-home message is limited doesn't mean less organs involved, and diffuse doesn't mean more organs involved. Any organ that can be involved in limited can be involved in diffuse and vice versa. It really comes down to skin scoring, which is with limited, you have less skin involvement. Diffuse, you're going to have more skin involvement. And what did I put here under systemic sclerosis is that there are other things that could fit under there, such as mixed connective tissue disease, otherwise known as the overlap syndrome. They have a positive RNP antibody, and overlap syndrome can definitely cause interstitial lung disease. And yes, there is something called scleroderma, which means scleroderma without the skin finding. Go figure it exists. This is a picture of morphia, of just the skin findings when we talk about scleroderma. Limited scleroderma, many of you remember the CREST syndrome, which is a nice little mnemonic when we talk about some of the characteristics when we talk about scleroderma. And of course, on your boards, the pulmonary boards, if they start talking too much about someone's nails, the capillary nail fold bed, really they're hinting at a scleroderma diagnosis. Limited and diffuse scleroderma, you could start evaluating them with an ANA based on the titer and the pattern. You could think about more specific antibodies. Limited scleroderma, anti-centromeres, the classic association. Diffuse, anti-topoisomerase, like in this question on the board exams. And with diffuse scleroderma, they have a higher risk of getting renal involvement. Don't forget renal crisis. That's why we try to avoid steroids in scleroderma patients. Lung, definitely interstitial lung disease and pulmonary arterial hypertension. And of course, some cardiac disease when we talk about this. So how do you die from, systemic sclerosis? The lung, pulmonary fibrosis, pulmonary arterial hypertension, And when we talk about scleroderma, please, I almost guarantee they're going to definitely ask you that on the board exams. So let me try to squeeze in one more question here because I know that I'm in this whole interstitial lung disease mode. So let me do one more ILD, then we'll kind of see if we're going to go to questions or not. So what about this 55-year-old woman presents with progressive dyspnea, cough over 8 months? Her medical history is notable for exercise-induced bronchoconstriction. Her meds are PRN, albuterol on physical exam. It's notable for some crackles on lung auscultation. PFTs, her total lung capacity is low, less than 80% of predicted at 70. Her FVC is low, less than 80% predicted at 65%. FEV1 is also low at 55%. DLCO is less than 80% at 65. And the ratio is on the higher side, classic for a restrictive intrinsic pattern. Get a high resolution CT scan of the chest, as you should anytime you think about interstitial lung disease. And here you go. Man, let's look at this CT over here. And already, you know what I see here? Dr. Raj's favorite cereal. What's my favorite cereal, everyone? That's right. It's honeycombs. So I see honeycombing, in the periphery, subarticular, maybe some traction bronchiectasis, which tells me, everyone, review your Fleischner Society guidelines from 2017 in regards to characteristics of a UIP pattern. Back to the question. They do a social history, and there you go. Owns a parakeet. And so I know all pulmonologists are listening to me today. So of course, you say parakeet, you know what I'm going with this. This is going to be one thing and only one thing, hypersensitivity pneumonitis. Now I want to make sure I spend some time and talk about that for the board exams. So, but my little pearl is anytime you're reading a vignette, it says parakeet on it, this poor patient is what? They're screwed. Never own a parakeet on the board exams. And when I teach internal medicine boards, I always say, don't go to a picnic on your board exams, because anytime you go to a picnic, you're done. You're screwed. You got HUS in 2 seconds if you go to a picnic. So this person with the parakeet, I don't sense good things. Which of the following test results would aid the diagnosis with the highest sensitivity? Yep, I'm playing that whole biostatistics game. I'm sorry. So, what are we thinking about here, everyone? It's no secret. Hypersensitivity pneumonitis. What is going to be the best way to diagnose this with the highest sensitivity? It's going to be a bronchoalveolar lavage, looking for lymphocytes. And I guess the cutoff is more than 35% lymphocytes. Should we do a transbronchial cryobiopsy? My interventional pulmonary people love doing that. They freeze the tissue and try to get big chunks. And also we'll do a little EBUS, I guess. Check serum IgG antibodies to avian antigens. All right. Or, hey, kind of doesn't make sense. Maybe do a methacholine challenge test here. So the answer is not going to be D. No one really thinks this is going to be asthma. And when it comes to these antibodies, don't get me wrong. I always order them, but you're going to make fun of me and say, but Dr. Raj, it really doesn't change your management. And you're right. Just because you have the antibody doesn't mean it's a trigger. And because you don't have the antibody doesn't mean it's not the trigger. So it really comes down to A and B. You know what I mean? And so I would say, based upon the wording of the question and really trying to going by guidelines, the answer is going to be what, everyone? Yeah, you guys are so awesome. I don't even need to be here. The answer is going to be what? Bronchoalveolar lavage. It's going to be the most sensitive, looking for what? Those lymphocytes over there, right? So let's talk about some hypersensitivity pneumonitis. Sometimes we refer to this as extrinsic allergic alveolitis. You could use these terminologies interchangeably. And who's going to get this? The answer is we don't know. We don't know who's, predisposed to having this immunologic reaction, getting this inflammation to all these different triggers. And what are going to be these triggers? Well, wow, there's like over 300 etiologies, So whether we're talking about farming or vegetable or dairy cattle or bird or poultry or grain or flour, there's so many triggers out there. And you know why I put this here? Because when we talk about UIP, pulmonary fibrosis, what is one of the common things that can go lead to that? Chronic HP, and most of us as pulmonologists say that if someone has a UIP pattern and we don't know why, I'm sure it may be idiopathic pulmonary fibrosis, or maybe it just could have been, chronic HP that we just really didn't know what the trigger was, But I use the word chronic, and I apologize because we're starting to go away from that terminology. So I know when I was taking my boards, in training, I used to call it acute HP and subacute and chronic, but it's so hard doing it based upon timing. So the American Thoracic Society, stated that maybe we should categorize them in two main types, fibrotic and non-fibrotic, and it really helps correlate what you should do with these patients. And and it does make sense to me. So when you talk about how do you evaluate these patients, well, of course, you want that exposure history. I mean, it's not wrong to check these IgG specific antibodies, but like I mentioned, their presence or lack of presence doesn't confirm or rule out any of these diagnoses. You definitely want to get imaging. If you say short of breath, of course, chest x-ray, PA and lateral first, but the minute you really think it's going to be an ILD, you really do need to get that high resolution CT scan of the chest. And I put a couple different images here. You see some localized honeycombing here. You see a diffuse ground glass over here. So it really can present in also a very big spectrum of disease when we talk about hypersensitivity pneumonitis. And of course, if someone knows what the provocative agent is, if they say, hey, when I'm away from my bird, I'm away from this job, I feel better, the response to avoidance also helps with the diagnosis. So with that being said, it really kind of leads me to talk about what? Diagnosis. So how do you do it? Well, if you got it really comes down to, do you have a classic history and physical examination and you know what the trigger is going to be? If that's the case, it's not wrong, to make the diagnosis based upon that. But let me just take a step back. Boom, boom, boom. And I know when we talk about HP that it is a multidisciplinary decision where we present the case with interventional radiology, pulmonary, interventional pulmonary, CT surgery, who do I forget? Pathology to really come up with the right diagnosis. But based upon air quote guidelines, they would say that the test with the highest sensitivity now that's minimally invasive really is doing a bronchoalveolar lavage. And of course, you really want to see a lot of lymphocytes. How many? Well, some numbers they throw out there is greater than 35%. But I'll tell you clinically, when I do get the cell with diff and I do a lavage, sometimes it goes way above 50%, Once again, getting a BAL with lymphocytosis is very supportive in the right clinical setting, but it's not diagnostic. And of course, all my fellows always yell at me and say, Dr. Raj, that makes no sense. Why isn't the answer a transbronchial biopsy? You're right there anyways. Why don't you just do the biopsy? Well, of course, you're looking for poorly formed granulomas, giant cells. You may not get them. It could be sampling error, and it is invasive in some cases. So even though many of us may do a transbronchial biopsy because you're just there, based upon this question, looking for sensitivity, you would just want to do that lavage with the cell with differential. You know what I mean? And of course, I put if necessary, where it's really going to change your management. Of course, that's why CT surgery comes to these multidisciplinary, events to get to chime in on their opinion. So I already told you what you see on diagnosis, why pathology is so helpful, looking for poorly formed granulomas, multinucleated giant cells. And of course, how do you treat? Well, number one, avoid. Easier said than done if you don't know what the trigger is. And it really comes down to, hey, if you have more of the non-fibrotic, kind of like the acute or subacute, I think it's very reasonable to try a course of oral steroids, But if we're talking about chronic fibrotic, they may not respond. You always want to think of how old is the patient? What are the comorbidities? Do they have bad CHF? Are they fluid overloaded? Do they have bad osteoporosis? And with all these things put together, you may or may not give a trial of oral steroids. And of course, when we think about steroid-sparing agents or secondary agents, the data isn't really robust. And the same two drugs we talked about for Sjogren's ILD is going to be used here, whether it's going to be talking about brand name Imuran or mycophenolate, and basically I choose the one that I feel comfortable with. I choose the one that has the better side effect profile for that individual patient. And of course, like we could talk about with any of these interstitial lung diseases, if they're symptomatic, refractory to medical therapy, of course, you always want to get them involved with lung transplant. I like this question. It's short, but it's deadly. Okay. So if I have any attendings listening here today, this is a great question to ask your fellows, but don't pick on the fellows. They're very hardworking. Okay. There's a 49-year-old woman with a long smoking history and has progressive dyspnea, and they do some spirometry. They only do spirometry, not doing like the full PFT. So what do they show? The FEV1 is 88% predicted. The FVC is 90% predicted. Both of those are what? Normal. They do the ratio, the FEV1 over the FVC, and it's normal at 82% predicted. Okay, where am I going with this? Which clinically significant disease process could be consistent with these pretty normal spirometry? All right. Is this normal spirometry consistent with a significant ILD, B, emphysema, C, chronic bronchitis with airflow obstruction, D, severe diaphragmatic weakness? So the answer is that if you have severe diaphragmatic weakness, what would the TLC be? It would be low. So I didn't even give you the TLC, but it would be a restrictive extrinsic lung disease. And if it's pretty bad, what would the FEV1 be in a really bad restrictive lung disease? It's got to be what? Low. What would the FVC be? Low. So it can't be severe diaphragmatic weakness. Would it be chronic bronchitis with airflow obstruction? Well, if you're telling me there's airflow obstruction, well, number one, what PFT parameter defines obstructive lung disease? Well, the ratio has to be what? Low. And especially the FEV1 has to be low. They're both what? Normal. So it can't be C. Significant ILD, not just that Sjogren's patient that we talked about earlier today. This is someone's significant ILD. So if you're going to have significant ILD, number one, there's no total lung capacity, but really the FEV1 and the FVC both have to be what? low, especially that FVC. When we talk about interstitial lung disease, it really has got to be low. All these are normal. So the only one I'm kind of bullied into it is someone who just has the quote emphysema. We're not even talking about mild, moderate, severe, just emphysema. So yes, emphysema is the correct answer because it really comes down to, is spirometry, even though that's the best and only way that we diagnose emphysema, is it good at detecting early emphysema? And the answer is not really, but it's all that we have. And that's why when we talk about COPD for your board exams, and I wanted to put this as the last question because COPD is the bread and butter for most pulmonologists like myself, that when we talk about how severe is your COPD, we just don't memorize spirometry anymore. Don't get me wrong. When we talk about the gold staging, it's going to be mild. It's going to be greater than 80, moderate, 50 to 80. If it's going to be 50 to 30, it's going to be severe. Less than, what's it called? Less than 30 is going to be very severe. So of course we have those, but we combine it with what? Their symptoms. You combine it with what? Hospitalizations and steroid use and questionnaires, like the MMRC and the CAT. So it's combining the symptoms and the spirometry, because there are some people that have normal spirometry and they're doing really poorly, and people with very poor spirometry that do well. So how can the spirometry be normal with emphysema? It really comes down to some of the physiology. So it really comes down to learners, is emphysema disease of the proximal airway or the distal? And the answer is the distal. And because it's the distal airway, I have to use two words when we talk about the word resistance: series and parallel. And when you're in series, resistance is going to be very high. But when you're in parallel, resistance is going to be very low. So when we talk about spirometry, hold your breath, blast it out. What are we really measuring? Things in the proximal airway. But emphysema is a part of the distal airway. So when we talk about the proximal airway, that's up here. This is in series, very high resistance. But emphysema is way down here. And look at this picture. Everything is branching. Things are in parallel. It's very, very low resistance. So what does that mean? To notice changes in your FEV1, to notice changes of resistance, changes in flow in the upper airways, you got to damage so much of your alveoli before you even start noticing changes in spirometry. And that's why people could have emphysema and have a normal spirometry. So with that being said, we only have 3 minutes left. Let me just kind of go all the way over here. And I'm so sorry to get to go all over these things, but couple things, everyone. If you have any questions, you could laugh at me. Everyone always laughs at me. You could actually, follow me on Instagram. I always respond to things on my Instagram. I definitely give out pearls and new articles and images. I have 2 podcasts. And one's a medical podcast. And I always give things from across internal medicine and other specialties. And I hope to see all of you one day. And most importantly, good luck on your pulmonary boards. I wish you all the best, and I know you do amazing. Thanks again for staying so long. Everyone here is amazing.